The coronary artery disease, known also as an ischemic heart disease, includes several conditions of myocardial damage due to a disbalance between the coronary input and myocardial needs. This picture illustrates the disbalance between the supply and the demands, causing the ischemia. The demands may be either normal or increased due to change in contractility, heart rate, systolic wall stress, and the supply may vary. Usually it is decreasing by the changes observed into the coronary blood flow. Clinically, the ischemia may demonstrate as chronic form, chronic ischemic heart disease. This is the stable stenocardia or the stable angina pectoris. Stenocardia and angina pectoris are synonymous terms. There is also another chronic form known as silent stenocardia or asymptotic ischemia. The acute coronary artery disease may demonstrate as an acute coronary syndrome with or without elevation of the ST segment. These conditions include the unstable angina and the variant angina of Prince-Metal. Another chronic form, characterized by complete coronary occlusion and elevation of the ST segment, this is the acute myocardial infarction. The progress of the ischemic heart disease may cause sudden cardiac death. The main etiologic factor for the ischemic heart disease, this is the atherosclerosis of coronary arteries. It causes obstruction and decrease of the blood flow through the coronaries, thus generating ischemia into the myocardium. The basis of the genesis of atherosclerotic process is the endothelial dysfunction and changes in the composition of the blood, especially hyperlipidemia. These factors, together with inflammatory change into the vessels walls, coronary walls, will cause platelet aggregation, fibrin production, and plaque growth and the acute coronary syndrome. The pathogenesis of the atherosclerosis briefly. The factors mentioned, the endothelial dysfunction and the changed composition of the plasma, especially the excessive level of LDL, are the cause for the penetration of LDL into the wall of the coronary arteries. There, they'll be engulfed by macrophages, and the macrophage loaded with fat will be converted to a so-called foam cells. Foam cell, this is a cell loaded with fats. Another source of foam cells, this is the proliferated smooth muscle cells pool under the effect of the cytokines released by the activated resident T cells. So finally, two sources of foam cells, the smooth muscle cells and the macrophages loading with fat cells, accumulation of fat-containing cells and fatty streak. This streak will protrude into the lumen and thus to cause narrowing of the lumen. Initially, the accumulation is eccentric. However, later it becomes concentric and the lumen will decrease. This is the Glagov's remodeling of the coronary artery vessels. This picture illustrates the progress of the coronary atherosclerosis. A normal blood flow initially. The plaque is growing here. First decreased blood flow, later the plaques will complicate with formation of thrombi. Further, obstruction, and finally almost full total occlusion and blood flow absent. This is the progress of the atherosclerosis in a vessel. The steps of this process are presented here on this picture. The first 4 steps are due. The plaque is growing mainly due to lipid accumulation and later fibrosis and thrombus formation. The first stages are clinically silent, while the advanced accumulation, the formation of the atheroma and finally fibroatheroma will cause clinically overt disorder. These steps from 1 to 6 are illustrated here, are non-complicated to the complicated plaque with a thrombus. In addition to the atherosclerosis, other factors may also contribute to the ischemic heart disease pathogenesis. For example, the spasm of a coronary artery. It may be due to physical exercise, but most commonly it is due to smoking, stress states, disuse of cocaine, misuse of cocaine, exaggerated use of cocaine, and others. Embolism. This is a rare cause of the ischemic heart disease. Usually, the emboli originate from the vegetation in endocarditis and also intravascular thrombosis in heavy smokers. Finally, inherited congenital anomalies are the rarest cause. For example, a unique coronary artery or atresia, a closed coronary artery. Usually, the obstruction is observed into the anterior coronary branches. Here, this is the most common site of obstruction of an artery in ischemic heart disease. The generation of a thrombus on the surface of a plaque is shown here. It is due first to platelet adhesion, followed by platelet activation, platelet aggregation, fibrin formation, and formation finally of thrombus with significant narrowing of the lumen of the coronary artery. The progression of the plaque is accompanied by a change in its composition. Initially, it is composed by lipids, but later thick fibrous caps are formed on the plaques, and later the complicated plaque with the thrombus formation will contribute strongly to a further narrowing of the lumen. So this is a stable plaque and this is an unstable plaque with a thrombus. In advanced ischemic heart disease, in fact, the fibrous tissues fibrosis contributes for 68% of the composition of the plaque. Lipid core is contributed for 16%, and also calcification is observed. The angina pectoris or the stenocardia is a clinical syndrome demonstrating with attack of chest pain. The chest pain is radiating, accompanied by shortness of breath, and sometimes even nausea and vomiting. The pain may irradiate to the left arm or to the mandible. It is caused by a transitory myocardial ischemia due to the narrowing of the coronary arteries and the decreased perfusion of the myocardium. This picture illustrates the 3 main types of angina: the stable angina, the unstable angina, and the variant angina of Prince-Metal. In stable angina, there is a thrombus formed. However, this thrombus is not complete. A plaque is formed, but however, there is no thrombus. It is not complicated with a thrombus, as shown here on this picture. The lumen is decreased up to 30% of the norm, 70% of decrease. However, there are not attacks of chest pain at rest. The pain appears when exercising due to the increased myocardial demands. In unstable angina, there is also a plaque, and the plaque is now complicated with a thrombus growing, as demonstrated here. Platelet aggregation and thrombus formation further decreasing the lumen, and also the thromboxane A2 released by the activated platelets will contribute additionally to a vasoconstriction, thus decreasing significantly the lumen of the coronary artery. The third form of angina pectoris, this is the variant angina of Prinzmetal. It is due to coronary spasm without plaque generation. This is illustrated here on this picture. A coronarography is shown documenting the huge spasm of the coronary artery causing a decreased supply of the myocardium and ischemic state. Unstable angina pectoris may demonstrate with chest pain, but also by a sense of strangling, accompanied sometimes by pain into the breast. The pathogenesis of the chest pain is not yet fully elucidated. It is illustrated on this slide. As you can see, several compounds are suspected to participate into the generation of the pain, but especially the role of adenosine is now well known. The adenosine is increasing in the ischemic myocardium, thus generating the pain, and the pain will be transmitted through sympathetic fibers to the brain. As already mentioned, the decreased supply of the blood is caused by coronary changes, and especially the decrease in coronary blood flow by 70% is enough to cause the syndrome of angina pectoris. If, however, progressing and exceeding 90 or more percent, this decrease of coronary blood flow will cause ischemic necrosis of the myocardium, myocardial infarction. Statistical data from autopsies indicate a presence of severe coronary artery luminal narrowing in 95% of patients with infarction, mostly atherosclerotic plaques. 90% of these narrowings are due to atherosclerotic plaques generation and non-atherosclerotic narrowing and generation because of other plaques generation in just 5%. In these 90%, in 77%, a thrombus was superimposed, a complicated plaque was present, and in 13% of the patients, no superimposed recent thrombus was observed. So, the decreased coronary artery flow is the most important cause for the ischemia causing ischemic necrosis and myocardial infarction. This slide illustrates the ATP production into the cardiomyocytes under aerobic condition. As we can see, there is no accumulation of lactate because it is metabolized in the presence of enough oxygen. Under ischemic conditions, because of the deficiency of oxygen, increased anaerobic glycolysis is present, and especially lactate will not be metabolized. Instead, it be increased in the heart muscle, thus causing metabolic acidosis, anaerobic glycolysis. The size of the necrotic area in myocardial infarction depends, of course, on the localization of the occlusion, also on the grade of the occlusion, incomplete or complete, on the presence of collaterals, on the myocardial demands, and of course on the duration of the occlusion. As shown here, the longer the duration, the harder the impact on the structure of the mitochondria responsible for oxidative phosphorylation and the production of energy. As we can see here, 40 to 60 minutes of no perfusion are sufficient to cause necrosis into the myocardium. So, it is important attacks of stenocardia to be treated immediately to not be converted into a myocardial infarction. Early treatment by coronary dilating agents. Let me note the heart attacks present with a clear diurnal rhythm, circadian rhythm. They are much more frequent in the morning after the wake-up and less frequent in the afternoon and especially by night. It is important to note also that the reperfusion, even being quick and adequate to restore the ATP synthesis and to restore the ability to contract of the myocardium, is also related to reactive oxygen species generation. So, mitochondria may be additionally damaged in addition to the ischemic conditions and to cause additional cell death. This is a complication of the reperfusion due to the intensive formation of reactive oxygen species in the reperfusion area. In myocardial infarction, there is a necrotic zone in the heart, the zone of the infarction, which is surrounded by a larger zone in which the tissue is injured. It is not yet necrotic. And one more surrounding zone, this is the ischemic zone. These three zones are responsible for specific change in the electrocardiogram. So it is important to note the use of electrocardiography if you suspect of an infarction is absolutely obligatory. This is here the normal ECG shown to compare with changes generated by the different zones. Necrotic zone generates a deep Q and enlarged QRS complex together with the inverted T wave. The zone of the injury causes an elevation of the ST segment, and the ischemia causes an inversion of the T wave. Now, taking in consideration the pathogenesis of the disorder, a disbalance between oxygen demand and oxygen supply, let's consider the possible approaches for treatment. We have to make a choice to decrease the oxygen demands or to improve the oxygen supply, or both. To increase the coronary blood flow, we need to use vasodilators, thus increasing oxygen supply to myocardium, especially calcium antagonists, entry blockers, but also statins and antithrombotics acting to decrease the role of the atherogenesis in the generation of perfusion deficiency. The oxygen demands may be decreased by agents decreasing the contractility or the heart rate, for example, beta-adrenergic agonists and eventually some calcium antagonists. Also, to decrease especially the afterload using calcium antagonists, entry blockers. Now, the next topic of the present lecture, disorders of arterial blood pressure, hyper and hypotensions. Let's first summarize how is the blood pressure maintained normally. It depends on two main factors, cardiac output and the peripheral resistance. The cardiac output is defined by the stroke volume and the heart rate, in other words, on the work of the heart, while the peripheral resistance will depend on either vascular structure or vascular function, mainly on the volemia, on the filling of the vascular system with blood, and on the caliber of vessels, depending on vasoconstriction, on vasodilation. They are the factors defining the peripheral resistance. The most common cause for the elevation of the peripheral resistance, this is the vasoconstriction. So, in this aspect, let me note the importance of the arterioles and precapillary sphincter because of their content of smooth muscle fibers. These areas are defining the maintenance of the peripheral resistance. This slide summarizes the characteristics of the hemodynamics in the cardiovascular system. It is presented oversimplified here. The whole cardiovascular system: aorta, arteries, arterioles, capillaries, microcirculation, venous veins, and vena cava here. The heart blood pressure is decreasing along the system. Here, as you can see, with the difference between the systolic and diastolic disappearing in the area of the microcirculation. Later, there is no more difference between systolic and diastolic pressures. This is the area microcirculatory area with the increased total area. This is the total area present here. It corresponds to the low resistance in this area. If the total area is decreased, the resistance will increase and the pressure also will increase. The velocity of the blood is shown here. It decreases along the circulatory system. This slide summarizes the role of different factors on the level of the arterial blood pressure. Let me remind the two main factors, the cardiac output and the peripheral resistance defining the blood pressure level. How are they controlled? The cardiac output will depend on the blood volume. The blood volume will in the same time depend on the level of the sodium. Let me remind that the retention of the sodium will cause water retention and hypervolemia. This may be due to the effect of mineral corticoids. So, the blood volume may be increased because of sodium retention due to excessive mineral corticoid secretion, and hypervolemia causing increase in the cardiac output. Cardiac factors such as heart rate and contractility, any factor increase in the contractility. For example, we are aware about the role of catecholamines, excessive production of catecholamines, for example, by a tumor of the medulla of the adrenal gland will cause increased catecholamines with excessive contractility and excessive cardiac output and hypertension. Humoral factors are summarized here. Vasoconstriction will increase the peripheral resistance. The main vasoconstrictor in our organism, this is the angiotensin II. Let me remind, this is the peptide generated by the system renin-angiotensin. Renin is released by the kidney to cleave the angiotensin 1 from the renin substrate, and later angiotensin 1 is converted to angiotensin 2 by a converting enzyme. Catecholamines also exert vasoconstriction in the periphery. Thromboxane, released by the platelets, leukotrienes, and endothelin, the factor released by the endothelium of the arteries, is also causing increased peripheral resistance. Let me know that neural factors, innervation, there is no parasympathetic innervation. The innervation is sympathetic. The alpha adrenergic stimulation will cause vasoconstriction, while in some areas beta adrenergic innervation may be present to cause dilation, but typically neural factor exerts vasoconstricting effect, thus increasing the peripheral resistance and increasing the blood pressure. Dilators, mainly prostaglandins, released into the periphery, especially inflammatory processes, will cause vasodilation, thus to potentiate the inflammatory response locally. But also kinins, bradykinin, also will cause vasodilation, and nitric oxide, a powerful vasodilating agent released by the endothelium. Some local factors also, such as pH changes, especially under hypoxic condition, may also influence the peripheral resistance. As you can see, the maintenance of the blood pressure is a complex process, and it may be modified by a lot of factors. This slide summarizes the well-known mechanism of blood pressure regulation. Baroreceptors in the carotid sinus, baroreceptor afferents to the vasomotor center into the medulla, and later the efferent nerve through the bulbospinal pathway to adrenal gland to the medulla, causing release of catecholamines, and also to the heart and to vessels, causing into the heart positive inotropic, tonotropic, batmotropic, chronotropic effects, and in the arterioles or venous vasoconstriction. Let me remind also that the reflex regulation of the blood pressure is rapid. It includes seconds to minutes. Chemoreceptors, baroreceptors, and some other receptors in central nervous system ischemic response are responding within minutes to increase the blood pressure, while the long-term maintenance of the blood pressure depends on the maintenance of body fluids, renal function, and especially the functioning of the renin production, renin-angiotensin-aldosterone system, rapid and constant regulation of the blood pressure. Normally, systolic blood pressure varies between 100 and 140 millimeters mercury, while the diastolic pressure varies between 60 and 90 millimeters mercury. However, as we can see, an increase may be observed with aging. with some small difference between males and females, both in systolic and diastolic blood pressure and also in the heart rate. Age-dependent changes of the level of the blood pressure and heart rate. There are two clinical types of hypertension: primary hypertension and secondary hypertension. The etiology and the mechanism of the primary hypertension are not yet elucidated. It contributes for more than 90% of all cases of hypertensive disease. The secondary hypertension is a syndrome related to a secondary elevation of blood pressure accompanying other diseases. It contributes for less than 10% of the cases of hypertensive patients. The elevated blood pressure itself is not causing some defined change, signs or symptoms in the patients. That's why the elevated blood pressure is diagnosed in usually asymptomatic patients because of another cause, regular examination because of medical insurance, for example. That's why the disease may progress till causing complications, and the diagnosis will be identified after the appearance of severe complications. That's why it is known, the hypertension, as a silent killer. Anyway, some signs and symptoms may be present, such as headache, fatigue, dizziness. However, their rate, the incidence, is not differing as compared with the appearance of the same signs and symptoms in normotensive patients. They are not specific. Thus, you have to check regularly the blood pressure of your patients and to reassess regularly. For example, in 5 years. This is done in patients with normal blood pressure, with levels below the borderline, 140 to 90 systolic diastolic. If marginal, however, the values near the borderline, you have to check these patients more frequently, for example, yearly. And don't forget, you have to take into consideration a specific characteristic of some patients. They are known as hyperreactors. They demonstrate increase of the blood pressure when measuring in the presence of a doctor, in the doctor's office. So, the remaining time they are fully normal. To obviate such an error, to qualify such a change as hypertensive disorder, you have to check the blood pressure by using ambulatory monitors, the so-called Holters. This is a portable recording device which is recording the blood pressure in the absence of the physician. So, it will demonstrate the absence of elevation during the nictemeron during the day and night in these normal patients. Anyway, the hyperreactors should be checked every year because they are at risk to develop a true hypertension later. And patient demonstrating an increase, constant increase of the blood pressure should be monitored and treated in accordance with the evolution of the disease. Sometimes the demonstration of a disorder may be the lack of the physiological diurnal rhythm of the blood pressure. Usually, the blood pressure is decreasing by night. These patients are known as dippers. However, the disappearance of the dipping may be the first sign of the hypertension. Thus, you have to use, if you suspect a non-dipper patient, you have to use the ambulatory monitoring, the Holter technique, to document the lack of nocturnal dipping and to diagnose hypertension. An early diagnosis will allow you to give treatment and to maintain a normal blood pressure in your patients, thus to obviate, to prevent the appearance of complications. Let's now review the putative complications of the hypertension. The elevation of the systemic blood pressure will cause an increased afterload for the heart. So, first, it will cause an adaptive response, left ventricular hypertrophy, which will end by causing diastolic dysfunction because of the thickening of the walls and the decreased compliance, and also later systolic dysfunction because of dilatation of the ventricles, or the progressing of the hypertension will cause heart failure. The increased afterload in the hypertrophy will also generate an increased myocardial oxygen demand. This is a precondition to generate myocardial ischemia and eventually myocardial infarction. The increased blood pressure, arterial blood pressure, also exerts an impact on arterial walls, thus causing arterial damage. First, this will cause acceleration of the atherosclerosis because of the damage of the endothelium, endothelial dysfunction, and the atherosclerosis will affect first, of course, coronary vessels, thus decreasing the myocardial perfusion and oxygen supply and creating a big risk for myocardial ischemia and infarction. The atherosclerosis in cerebral vessels creates a risk for ischemic stroke, and atherosclerosis in aorta may cause damage to the wall and eventually aneurysm, dilatation of the aorta, and even desiccation of the aorta. The arterial damage of the walls will weaken the walls and thus will contribute for the aneurysm and dissection of the aorta. In the cerebral vessel, destruction, rupturing of the vessel, hemorrhages, and hemorrhagic stroke. In the renal vessels, nephrosclerosis, loss of glomerular vessel, and progressive renal failure. And ophthalmic vessels damage will cause retinopathy. As you can see, a lot of complication, and our goal is to achieve an early diagnosis to treat effectively and to prevent all these complications. Now, the secondary hypertensions. As already mentioned, they are relatively rare. They collectively contribute for less than 10% of all hypertension cases. First, let me note the coarctation of the aorta. It represents a congenital narrowing of the aorta, thus increasing the peripheral resistance into the aorta and increasing the afterload to cause hypertension. In some patients, rarely, there is an increased salt sensitivity, especially in people practicing high salt intake. This genetic predisposition will cause increased sodium retention, water retention, hypervolemia, and hypertension because of increased afterload. Some renal abnormalities also may generate hypertension. For example, the atherosclerosis of the renal artery, thus causing narrowing of the artery and hypoperfusion of the kidney. The same state is produced by fibromuscular dysplasia of the renal artery. The decreased perfusion of the kidney will stimulate the renin secretion by the kidney and the formation of angiotensin II, acting on angiotensin receptors and to cause vasoconstriction and to increase the blood pressure. This is illustrated on the next slide. The reduced renal blood flow stimulates the renin release, increases the angiotensin II formation, and causes systemic vasoconstriction, thus increasing the blood pressure. This hypertension is known as high renin hypertension because of the excessive release of renin, it may be treated by using the inhibitors of the angiotensin 1 conversion. Angiotensin converting enzyme inhibitors will prevent the generation of angiotensin 2 and the vasoconstriction. In another case of renal hypertension, the hypertension may be generated by another pathogenetic mechanism. For example, in chronic glomerulonephritis and loss of parenchymal tissue, the decreased function of the kidney will cause sodium retention, and as a consequence, water retention, hypervolemia, increased blood volume, and hypertension because of the increased peripheral resistance. This type of hypertension is not related to excessive renin production. Instead, the hypervolemia will suppress the renin production. So, this is a case of low renin hypertension. It cannot be treated by using angiotensin converting enzyme inhibitors. They are useless. Instead, we have to decrease the blood volume using diuretics. There is also a rare case of renal disorder, the so-called Little syndrome, in which because of genetical damage, there is an increased renal sodium reabsorption. So, as a consequence, sodium retention and hypervolemia causing hypertension. The Little syndrome causes hypertension. Hypertension is also observed in some women taking the so-called anti-baby pills, hormonal preparation preventing the pregnancy. However, in some women, the angiotensinogen formation, the renin substrate, is strongly stimulated, so there is an excessive formation of angiotensin 2 and hypertensive response. The angiotensinogen formation into the liver is stimulated by anti-baby pills. This is the so-called pill hypertension in women. Hypertension may be produced also secondarily because of adrenal gland disorders. For example, mineralocorticoid excess. This is the primary hyperaldosteronism, most commonly due to a tumor of zona glomerulosa producing the aldosterone. The increased level of aldosterone, this is the characteristic of the Cone syndrome, will cause increased sodium retention and as a consequence fluid retention, the hypervolemia, expansion of the extracellular fluid volume, increased plasma volume, and hypervolemia with increased cardiac output and hypertension. In addition, because of the interaction with the other regulatory factors, increased vascular smooth muscle contractions will be observed together with vasoconstriction and increase of the peripheral resistance, contributing also to the hypertension. However, the main effect remaining into the pathogenesis, this is the fluid retention and the hypervolemia causing the increased heart output. Hypertension in Cone syndrome, excessive production of aldosterone, hyperaldosteronism. In another adrenal disorder, there is also secondary hypertension. For example, in Cushing syndrome. Cushing syndrome is characterized by hypercortisolemia, as shown here. As you know from the physiological course, the cortisol is responsible for the maintenance of the vascular reactivity to vasoconstrictors, especially to catecholamines. So, if increased the level of the cortisol, increased reactivity to vasoconstrictors will cause massive vasoconstriction with increased total peripheral resistance and hypertension. And in addition, the excessive level of cortisol will allow the cortisol to bind to mineralocorticoid receptor and to cause water rotation, hypervolemia, increased plasma volume, increased cardiac output, and to contribute to hypertension. Despite the low affinity of the glucocorticoid hormone cortisol, at high concentration it will bind also to mineralocorticoid receptors and to cause increase of the extracellular fluid because of sodium and water retention and hypertension. This is the mechanism of the secondary hypertension in Cushing syndrome due to the hypercortisolemia. Secondary hypertension may be due also to excessive secretion of catecholamines, for example, by a pheochromocytoma, a tumor of the chromaffin tissue of the medulla of adrenal glands. However, because of the presence of a chromaffin tissue outside of the medulla of the adrenal glands, sometimes extra-adrenal pheochromocytoma may also be present. It is characterized by excessive production of catecholamines. It secretes noradrenaline or adrenaline or both. When noradrenaline is secreted, a sustained hypertensive response is achieved with paroxysm, elevation at extremely high levels of the systolic and diastolic blood pressure. The paroxysmal elevations of the blood pressure in pheochromocytoma patients are accompanied by headache, palpitation, and abundant sweating due to the excessive level of catecholamines. This slide summarizes the approaches for treatment in accordance with the pathogenesis of the corresponding type of hypertension. For example, blocking of the vasomotor centers or sympathetic nerve terminals release, receptors in vessels and vascular smooth muscle receptors especially, or preparation actins to the kidney, blockers of the angiotensin converting enzyme as already mentioned. We are now going to discuss the disorders characterized by decreases of blood pressure, the hypotensions. They may demonstrate either as acute hypotensions or chronic hypotensions. The acute hypotension presents under two different forms: generalized shock and localized, especially to the brain circulation. This is the syncope. Let's first consider the syncope. It is known also under the name of collapse, because this is a brief, sudden transitory loss of consciousness and falling down, collapse, because of cerebral ischemia due to decreased perfusion, decreased blood flow to the brain. It may be caused even by transition from supine to upright position. Look here, the transition from supine to upright position is characterized by a decrease in abdominal lymph flow in the cart output by 25%. The stroke volume is decreased by 40%. All these reactions may cause decreased perfusion of the periphery and decreased supply of the brain, thus causing the syncope. However, normally these changes are very rapidly corrected within seconds by the corresponding autonomic reflexes. However, in some people, the deficiency of the autonomic reflexes may cause an orthostatic syncope when the transition, especially from supine to upright position, is rapid. This may cause a syncope. Syncope may be caused also by emotional stress, by an unpleasant environmental, by painful manipulations, by starvation, sleep deficiency, and overtiredness. In any cases, there is a decrease in the perfusion pressure through the brain. This slide summarizes the mechanisms of hypotension two main group of causes: cardiac mechanism and vascular mechanisms. The vascular mechanism including vasodilation or obstruction, and the cardiac changes, especially the low output, may be due to hemodynamic changes because of arrhythmias or structural disease, valve damage, ischemic heart disease with decreased contractility, and so on. And also hypovolemia because of hemorrhage, loss of fluid because of diarrhea, dehydration, and drugs, diuretics. All these causes will cause hypotension. The acute form of hypotension, the general hypotension, is known as shock. Shock represents an abnormality of the circulatory system in which there is an inadequate tissue perfusion due to a relatively or absolutely inadequate cardiac output and supply of blood to the tissues. There are four main causes. First, inadequate volume of blood to fill the vascular system. This is the hypovolemic shock. Or increased size of the vascular system because of vasodilation, for example, into the venous system. Thus, there is no normal volume, blood volume, into the arterial portion. This is the distributive shock. Another type of shock, this is the inadequate output of the heart because of myocardial abnormality. This is the cardiogenic shock. And finally, inadequate cardiac output as a result of obstruction of blood flow into the lungs or into the heart. This is the obstructive shock. Let's now start the discussion with the hypovolemic shock. Main causes of hypovolemic shock are the hemorrhage and dehydration. Hemorrhagic shock is especially the more severe form, and it is sometimes considered as a different type of shock. Hypovolemia may be due, as already mentioned, to hemorrhage or to severe dehydration because, for example, of fluid losses, vomiting, diarrhea, but also to burns, loss of plasma, plasmorrhagia from burn surfaces. Surgical trauma also may contribute to hypovolemia. Traumatic, battle accidents, crash syndrome also may contribute to the hypovolemia. The main change in the hypovolemia, this is the decreased blood volume and the decreased preload to the heart. As a consequence, due to hypovolemia, blood pressure is decreasing. The decreased preload to the heart will cause a decrease into the heart output because of decreased stroke volume, and as a consequence, decreased perfusion to the periphery, decreased supply of all organs into the body. This is a generalized circulation disorder. The patients with hypovolemic shock are pale. Their skin is cold and clammy. They report intensive thirst and oliguria. Hypotension, as already mentioned, is also observed. A compensatory response observed, this is the tachycardia. A rapid steady pulse, pulsus filiformis, is observed, and also another adaptive response, this is the tachypnea observed in these patients. Other compensatory responses to hypovolemic shock activated by the hypovolemia are the vasoconstrictions of both arterial and venous vessels, the increased production of some hormones such as vasopressin, glucocorticoids, renin and angiotensin, and also erythropoietin. These are the compensatory responses to hypovolemic shock. Sometimes the shock turns to be irreversible. This is the so-called refractory shock. Even the blood volume is returned to normal, the cardiac output remains depressed, and the patient will die because of no response to vasopressor drugs. This is the refractory severe hypovolemic shock. The second type of shock, this is the distributive shock. It may demonstrate most commonly as anaphylactic shock or septic shock. In anaphylaxis, there is an increased release of histamine, thus causing vasodilation, especially venous vasodilation, and sequestrating the fluid, the blood, into the venous circulation because of decreased peripheral vascular resistance, a huge decrease caused by the venodilation as a result of release of histamine in anaphylactic shock. So, the sequestration into the venous portion of circulation will cause a decreased blood pressure into the arterial section and decreased cardiac output, stroke volume, and decreased perfusion of the periphery. This is the case of distributive shock. A similar picture is produced in sepsis, a redistribution, especially sequestration of fluid outside of the arterial system. It may be combined, the septic shock, with some components of cardiogenic shock, as I will discuss a little bit later. Also, neurogenic shock, not presented here, may cause a huge peripheral vascular resistance and to cause a redistribution with decreased blood pressure and hypoperfusion of the periphery. The third type of shock, this is the cardiogenic shock. It represents an impairment of pumping function, thus causing decreased blood pressure, decreased cardiac output because of decreased stroke volume, and decreased afterload of the heart. Typically, the cardiogenic shock is due to an extensive myocardial infarction with loss of cardiomyocyte, necrosis of cardiomyocyte. Less commonly, it is due to other disease, decreasing the ventricular function. In this case, a congestion of lungs and viscera is observed due to the failure of heart to put all the venous blood returning to it. This is the characteristic congestion of the lungs and lung edema in cardiogenic shock. Mortality rate in cardiogenic shock is extremely high. It exceeds 60% and may achieve 90% mortality rate. The fourth type of shock, this is the obstructive shock. It is due to a massive pulmonary embolism. The tension pneumothorax with kinking of the great veins and bleeding into the pericardium, thus external pressure on the heart exerted, cardiac tamponade, also may cause an obstructive shock. Let me remind, in this last case, pulsus paradoxus, the arterial pressure falling during inspiration will be observed due to the increased intrapericardial pressure. Obstructive shock, this is the last type of shock to discuss today. Let me now mention briefly the chronic hypotension. It is known also as primary essential hypotension. It is due to a disbalance between the vagal tone and the vasopressor factors in the organism. It demonstrates by chronically lowered arterial blood pressure with tiredness, bad sleep, lack of emotional stability, and even impotence. This is the picture of the primary chronic hypotension. It may be caused secondary to another disorder because of suppression of pressure response or activation of a depressor mechanism. For example, stenosis of mitral valve will cause a decreased stroke volume and hypotension. Emphysema and bronchial asthma secondarily will also cause hypotension. Endocrine disorders, for example, hypofunction of adrenal cortex in Addison disease, will cause sodium loss, decreased extracellular volume, decreased pressure effect of catecholamines, and hypotension. Some infectious disease, metabolic disturbances, such as diabetes, severe hypovitaminosis, and starvation, may also cause chronic secondary hypotension.